Hello everyone. During this lecture, we will continue with the second part of hemolytic anemias. So far, we have talked about spherocytosis, hereditary spherocytosis, and sickle cell anemia. The third type of hemolytic anemia is the thalassemia. It's an inherited disease due to mutations in the globin genes. These mutations leads to the decreased synthesis of alpha globin or beta globin genes, leading either to alpha thalassemia or beta thalassemia. Now, the adult hemoglobin, as we mentioned previously, is a tetramer of two alpha chains and two beta chains. Decreased synthesis of one globin chain will lead to deficiency of hemoglobin and red blood cell damage by the precipitates of the unpaired normal globin chains. So if we have a deficiency of beta globin chains, for example, the unpaired alpha globin chains will precipitate in the cell, leading to toxic damage to its membranes. Thalassemia is common in Mediterraneans, in Africans, and in Asian regions. Again, it protects against malaria, as in sickle cell anemia, due to the decreased lifespan, markedly decreased lifespan of the red blood cells. And there is wide variation in expression depending on the combination of the mutated alleles. So we'll start with beta thalassemia. Beta thalassemia, we have a single beta globin gene, which is located in chromosome 11. The mutations leading to beta thalassemia are two types of mutations. It's either beta 0 mutation, in which there is no beta globin chains are produced at all, and beta plus, in which there is a reduced beta globin synthesis. We have more than 100 different causative mutations, and these mutations are characterized by a single base mutations. Beta thalassemia minor, beta thalassemia major, and beta thalassemia intermediate, in which it's an intermediate stage between two. The beta thalassemia minor, or what is said to be the beta thalassemia trait or the carrier state, those patients, they inherit one abnormal allele of the beta globin, and the other allele will be normal. So these patients are either asymptomatic or mildly symptomatic. The beta thalassemia major, we have two mutated alleles, whether they harbor a beta 0 mutation or a beta plus mutation. So definitely those patients will have markedly decreased levels of beta globin or even absent beta globin synthesis. So as you can see here, beta thalassemia minor, the patients are said to be heterozygous for beta thalassemia, in which one globin gene, beta globin gene, is normal and the other is mutated, whether the mutation is beta 0 mutation with no globin chain produced, or beta plus, in which it is decreased. Those patients are asymptomatic or mildly symptomatic. The beta thalassemia major, the patients are homozygous, so the both alleles are mutated, whether beta 0 mutation, both beta 0 mutations, both beta plus mutations, or one beta plus and one beta 0 mutation. So those patients will have severe anemia and they need regular blood transfusions in order to keep them alive. The mutations are mainly point mutations, leading to defects in the transcription of the beta globin gene. The defective synthesis of beta globin by the mutated beta globin gene leads to anemia by either inadequate hemoglobin A formation, the adult type hemoglobin, resulting in small, microcytic, hypochromic red blood cells, small size reflected by low MCV and the complete blood count, الفحوصات المخبرية, and decreased size and increased central pallor reflected in the peripheral blood smear. Accumulation of unpaired alpha globin chains leads to the formation of toxic precipitates, which will damage the red blood cell membrane and the erythroid precursors in the bone marrow. Those patients will have ineffective erythropoiesis, in which there is increased proliferation of erythroid precursors in the bone marrow, but the toxic precipitates of alpha globin chains will lead to their damage immediately. So they die in the bone marrow. So it will be reflected by decreased red blood cells in the peripheral blood. So we call it ineffective erythropoiesis. The red blood cells which are produced have a shortened lifespan because of the deposition of the unpaired alpha globin chains, which will lead to toxic damage. And those patients will have increased iron absorption because of the increased erythropoiesis, which is ineffective. As I said, the anemia will lead to increased iron absorption from the gut, and the iron will build up in the body, leading to secondary hemochromatosis. So the pathogenesis, again, in normal erythroblasts will produce normal hemoglobin, which is the adult type hemoglobin, which is a tetramer of 2 alpha chains and 2 beta chains. Normal erythroblasts will give normal red blood cells. When there is a reduced beta globin synthesis in patients with thalassemia, with excess of alpha globin, in the bone marrow, the abnormal erythroblasts will die immediately or early in the process, and this is called ineffective erythropoiesis because of the insoluble alpha globin aggregates that form in the cytoplasm. Even in the few red blood cells that exit to the peripheral circulation, they are abnormal red blood cells because also they have precipitates of alpha globin, which has a damaging effect. The cells are small in size and hypochromic with increased pallor in the center. These cells, when they pass in the spleen due to the presence of these unpaired alpha globin aggregates, they will be engulfed by the splenic macrophages, leading to extravascular hemolysis and anemia. The ineffective erythropoiesis and the use of iron extensively in the bone marrow will lead to increased iron absorption from the gut, and this iron will build up in the body, leading to iron overload. It will accumulate or precipitate in the heart or in the liver, which we call it secondary hemochromatosis. So these patients will be anemic due to the ineffective erythropoiesis and due to the extravascular hemolysis. The anemia will lead to tissue hypoxia. Tissue hypoxia leads to erythropoietin production, increased erythropoietin production from the kidney, and this will in turn go to the bone marrow to stimulate more erythroid hyperplasia, leading to marrow expansion and skeletal deformities. Also, these patients are kept on blood transfusions. Repeated blood transfusions also will build up iron in the body, adding to the secondary hemochromatosis. The alpha thalassemia, we have 2 alpha globin genes on chromosome 16. So in total, we have 4 alleles for the alpha globin. Mutations in alpha thalassemia are different from the point mutations in beta thalassemia. Here, the mutations are deletions, in which the whole gene is deleted. We have 4 alleles, so one of them or more will be deleted, and this will be reflected by different manifestations or types of the disease with variable severity. If we lose a single alpha globin gene, this is called the silent carrier state, and the patient is usually asymptomatic. If we have deletion of the 4 alpha globin genes, the fetus will die in utero, lethal in utero. We call that hydrops fetalis. And if we have loss of the 3 alpha globin genes, the patient will have a relatively stable beta 4 tetramers, which we call it hemoglobin H, or gamma 4 tetramers, we call it hemoglobin part. Those patients also will have ineffective erythropoiesis, but it is less pronounced than in beta thalassemia. The hemoglobin H and part hemoglobin, which are formed of 4 beta chains or 4 gamma chains, respectively, are inefficient in oxygen delivery because they have a high affinity for oxygen. That is, they will not leave the oxygen easily, so the tissues will suffer from hypoxia. The morphology, whether it is beta thalassemia or alpha thalassemia, the findings on the peripheral blood, if the patient is beta thalassemia minor or alpha thalassemia trait, what we will see only is the microcytic hypochromic cells, small size with increased central pallor بالإضافة للtarget cells. In patients with beta thalassemia major, there will be marked microcytosis, markedly decreased size of the red blood cells, and hypochromia with increased pallor, central pallor of red blood cells. Also, we have poikilocytosis, which is variation in the cell shape, and anisocytosis, which is variation in cell size. Also, we have normoblasts that appear in the peripheral blood, nucleated red blood cells due to the increased erythropoiesis. So, red blood cells with a nucleus will start to appear in the peripheral blood. As you know, the erythroblasts, they have a nucleus, but upon maturation to a mature red blood cell, they lose the nucleus. So we are left with red blood cells that are enucleated normally. The changes are less severe in patients with hemoglobin H disease and in patients with beta thalassemia intermedia. The clinical features of iron deficiency anemia must be excluded دائما in the setting of beta thalassemia minor and alpha thalassemia trait because those patients are asymptomatic most of the time or mildly symptomatic, and the only manifestation is a microcytic hypochromic red blood cells, which also can be seen in iron deficiency. So دائما we have to exclude an iron deficiency anemia before attributing that to a beta thalassemia or asking for electrophoresis to confirm a beta thalassemia minor or alpha thalassemia trait. The beta thalassemia major manifests postnatally as the hemoglobin F synthesis diminishes. So it will not manifest immediately. It needs time to appear once the fetal hemoglobin is converted to adult type hemoglobin. Those patients will suffer from skeletal deformities زي ما حكينا, splenomegaly, hepatomegaly, and lymphadenopathy, growth retardation, and cachexia. Patients are sustained by blood transfusions. They need blood transfusions regularly to improve the anemia and reduce the skeletal deformities. The blood transfusions will add to the iron overload. So unless these patients are treated aggressively with iron chelators, cardiac dysfunction from secondary hemochromatosis can occur. Diagnosis of beta thalassemia major is by hemoglobin electrophoresis, which will show a profound reduction or absence of hemoglobin A, the adult type hemoglobin, طبعا حسب طبيعة الميوتيشن, and increased levels of fetal hemoglobin. The hemoglobin A2 also level may be normal or increased. In the beta thalassemia minor, there will be a reduced level of adult type hemoglobin, the hemoglobin A, but it is less than in beta thalassemia major with increased levels of hemoglobin A2. So we need electrophoresis in order to confirm the diagnosis. The last hemolytic anemia is glucose 6-phosphate dehydrogenase deficiency, which is a recessive X-linked trait, which means it is more symptomatic in males. Females are usually either carriers or need two mutated alleles to manifest the disease. Carrier females will have two populations of the red blood cells, one population with deficient G6PD enzyme and one population with normal enzyme. We have too many variants of the G6PD, more than 400 variants, but only few of them will cause the disease. The mutations إما بتؤدي إلى deficient G6PD أو non-functioning G6PD. طبعا الأسوأ هي non-functioning G6PD, which is the Mediterranean type. What's the function of the glucose 6-phosphate dehydrogenase enzyme? It is to regenerate the reduced form of GSH, which is considered an antioxidant. This process is impaired in patients with G6PD deficient cells, and the red blood cells they do not have a nucleus, so they do not synthesize enzymes. So the enzyme that is lost in older red blood cells will be more sensitive to the oxidant damage than the new red blood cells, which have a more abundant enzyme. The pathogenesis of this disease, episodes of intravascular hemolysis will take place by exposure to any environmental factor, whether infectious or drugs, leading to an oxidant stress. Oxidants will attack the globin in the red blood cell. Oxidized hemoglobin will precipitate in the red blood cell and leads to the formation of Hens bodies. These Hens bodies will lead to damage of the red blood cell membrane, leading to intravascular hemolysis. So the hemolysis here is within the vasculature, not in the spleen, as in the sickle cell anemia or spherocytosis or in thalassemia. The splenic macrophages also will identify these Hens bodies, which are oxidized hemoglobin precipitates, and pluck them out, resulting in the appearance of white cells also in the peripheral blood. So, as I said, these patients are mainly have a deficiency of the enzyme needed to regenerate the reduced form of glutathione. So, this will lead to oxidant stress induced damage. So as you can see here, these are the red blood cells with Hens bodies in the cytoplasm, okay? And these are the white cells after their passage through the spleen. The clinical features, those patients will be normal unless exposed to any stressful condition like infections or certain drugs or favism أو التفول. The hemolysis usually typically starts after 2 to 3 days من الدرug exposure أو من infection, and usually it's associated with pain crisis. As I said, the most common triggers هم infections because they lead to the formation of free radicals, and some drugs, mainly the anti-malarial drugs, the sulfonamides and the aspirin, بالإضافة إلى الفافا beans. And thank you.